Very pleased to be here. I'm just back from a few days travelling, and briefly in the context of dementia-friendly communities. Washrooms? How many different ways are there to turn on taps and find soap and dry your hands? Somebody needs to sort that out, I think. Right, so what I'm really here to talk about is what NICE has done in relation to the Dementia Challenge, what we've done in relation to the evidence for prevention, early diagnosis and treatment, and we've issued a range of guidance and quality standards, and I'll finish with a little bit of information about progress to date. And some of this might reflect things you've already heard, but I'll bring it into a nice context. You'll all be aware that the prevalence of dementia goes up quite dramatically with age. And this is, in many ways, a success, isn't it? All the new drugs that we see at NICE, all the new technologies that prevent cardiovascular disease, that treat cancers, those are all great things. It means we're all living longer. But as we live to be older, we sadly are getting more dementias. So if we can find a way of preventing dementia, that would really be a fantastic thing. I found some interesting information on the internet showing where the highest rates of dementia happen to be. New Forest, West, North Norfolk, undoubtedly due to there being a higher population of older people, and absolutely not a case of prevention of dementia being a recommendation from NICE not to live in New Forest, West or North Norfolk. Angela mentioned in her introduction NICE and the context of drugs, and we do look at cost effectiveness. And the total cost of dementia back in 2013, I'm sure it's even higher now, but that was the last figure I could find, was 26.5 billion. So as well as the impact on us and on our families and carers and society, it is a huge financial burden. So NICE's role in what we do and how we look at budgets and cost is really crucial in this context. The statement here sets out NICE's role. We provide national advice, national guidance on what works, what's safe, and what's good value for money. And it is in the context of a resource-constrained system. We can't get away from that. However much money we might think we needed, there are always going to be budgetary constraints. NICE's core role is taking evidence, issuing guidance. From that, we develop some standards, all absolutely with the aim of improving the outcomes for patients and carers and the public. I'm not going to dwell on our methods. I've just got this one slide, and I do want to emphasise that we look at all the evidence that is available for a particular topic. There's a bit of a misconception that we only ever look at randomised controlled trials, but we don't. We look at the whole gamut of the evidence, which is a really, really big task, as you can imagine. Everything we produce is based on the best available evidence, but we also have input from experts, from patients, from economists, and from the public. The evidence is never black and white, so you very much need a group of people who will give you an independent, unbiased perspective on what it means. So our independent advisory committees are crucial to our guidance development. We always consult with stakeholders. We sometimes change our minds, and that's a good thing. It's not what the Daily Mail might say. It's not a U-turn. It's actually listening. We regularly review and update our guidance, and we do it all as openly and transparently as we possibly can. I'm really pleased to say that we have done a lot of guidance that's relevant to dementia and the prevention of dementia. I haven't put it all on this slide, but some key things. We did many years ago, over 10 years ago, issue our first guideline on dementia. And we then provided one that supplemented that, which was around dementia and supporting carers and the social care component of the clinical management of dementia. We're now updating both of those guidelines, the clinical and the social care components, in one large guideline due to be published in June 2018. We've also produced a guideline looking at midlife approaches to prevention, and I'll say a little bit more about that one in a moment. And of course, we have looked at the drugs for dementia, and we've recommended some of those for use in the NHS. There was controversy around those, as I'm sure you're aware, but I'm not going to dwell on that. There's also some advice that we produce. It's not formal guidance, it's not mandated in terms of funding, but we have also looked at using low-dose antipsychotics in people with dementia and recommended against that, and we've looked at other ways of managing symptoms, behavioural disturbances in people with dementia. So there is a lot of work that we've done. The easiest way to find all of that, if you're interested, on the NICE website, is looking for something that says pathways, and then you'll see it all mapped together, and it's much, much easier to navigate than if you were going in and out of every different piece of guidance. So just for a moment, going back to the value for money element of NICE's work. We do have to take difficult decisions around which drugs the health service can fund and which ones we can't. And we bring together quality of life and length of life and value that. We've got that across the bottom of this graph. And the higher the cost per QALY, the less likely we are to say it's not good value for money. So those things that fall into the red box at the top that cost more than £35,000 per QALY, we will usually say no to. Things that relate to end of life or things that relate to very rare conditions, we might say yes, even though they have a very high cost attached. It isn't a straightforward decision. But one of the important points of this slide, and the reason why I wanted to show it, was because down there in the middle of the green box are some little crosses. And our public health team was really pleased when they applied the methods we use for new drugs to preventive interventions. And those are things from the public health programme, which really do show, I think, that prevention is better than cure. If we want to prevent dementia, we need to know what it's caused by. And it is caused by a range of different things. It's not just a thing. And they all combine to cause damage to the brain and the way the brain works, either because of some simple traumatic event or because of a complex degenerative condition. Most of the causes of dementia relate to Alzheimer's disease, that pale blue on the slide, quite a big proportion from vascular disease, and some that is mixed, the yellow. There's also another type called Lewy body dementia. So a complex picture, and the data isn't entirely in agreement, but this is a rough overall picture of how the patterns do occur. Some people will say there is some vascular dementia in all cases of dementia, but it's mixed. But because of the different patterns of dementia, there isn't one easy answer to prevention. And if we think just specifically for a moment about Alzheimer's disease, I think you had a talk this morning. Unfortunately, I wasn't here, but you had a talk, didn't you, about new drugs. And there are new drugs under development for mild to moderate Alzheimer's disease, which is good news. At the moment, they're targeted at this thing called amyloid, which you find in the brain. But there is other research going on to look for different mechanisms that might be better than the drugs that target this amyloid. And there's also a lot of interest in doing some preventive research. The drugs for Alzheimer's are targeted at people who have early or moderate dementia, and there are symptoms. It would be much better, wouldn't it? Much better to prevent it in the first place. And that is absolutely the goal. If you do that, though, you're probably going to need to treat people from their 40s. And therein, at the moment, is the challenge. The challenge is recognizing people in their 40s. And as I understand it, there are two ways that we might go about it. There's one approach, which is to improve the imaging of the brain so you can pick up really, really early signs in people in their 40s and use some new drug to prevent any worsening. Or we need to get better at the tests that we apply to people that show how brain function might be changing in a very, very subtle way that we wouldn't otherwise pick up. So hopefully there will be progress in the future at preventing Alzheimer's. I said I'd mention our guideline on midlife approaches to prevention. And here we looked at all the research that there was in relation to preventing dementia. It wasn't just Alzheimer's, it wasn't just vascular dementia, it was all types. There was some interesting research that seemed to show that if you'd ever had a general anaesthetic, it reduced your risk of having dementia. We couldn't work that one out at all. The committee debated it. They decided it was probably spurious. So we haven't recommended to try a general anaesthetic just in case. What we did find when we looked at the various risk factors was that the pattern was, as you might expect, in relation to those things that cause vascular disease. Because vascular disease can cause dementia, so things like smoking increases your risk of dementia, things like exercise decrease it. So we should all do these things anyway. They might or might not stop us getting dementia, but they will be good for us. There is some evidence that in your midlife, it is important to stimulate your brain. Cognitive stimulation can have benefits. You should vary the types of things that you do. I'm aware of the time, so I shall go quickly through the last few slides, which emphasize, again, we go from evidence to guidance to standards, and standards are a small number of prioritized statements where we know things need to improve. That's the key thing about NICE standards, where improvement is needed. They are also focused and measurable. At the moment, there are two dementia standards, one with a focus on healthcare and one on the social care quality and experience of care. So overall, there are 20 statements. We also have a separate standard on mental well-being of older people in care, which might also be relevant. Just illustrating this for a moment in case you haven't seen them. The standard that's about living well with dementia, as I say, it has 10 statements, and they should be read alongside the healthcare standard. The first one, discussing concerns about possible dementia. Really important. The rationale, of course, which I'm sure you all know, is that if you have or a relative has symptoms of dementia, getting a diagnosis can help make informed decisions about what you want to do next. And it's quite sad for me reading this, because my mother, who lives on her own in her 80s, has become much more much more disinclined to go out, takes much less care of her appearance. She doesn't cook like she used to. And just suddenly this last week, I thought, I think she might have dementia. And when that penny drops, you just think, what do you do next? You need to have a conversation with someone and discuss it. So finally, though, measuring progress is important. There's an old saying, measurement drives improvement. And I don't want people to be obsessed with measurement, but if you think about those quality standards from NICE, and if those can be used to drive some improvement in areas where we know change is needed, that would be great. I think Charles Alessi talked about measurement this morning. We track as much as we can progress against our quality standards, but there isn't very much, and I'd like there to be more. This was some data that I found on the NICE website, because we've pulled it all together, about progress in case finding in hospitals. And most of the data is in hospital. It would be great to get some from the community. But at least it's showing progress. So, in summary, there are a range of different causes of dementia. So we will need different approaches to prevention. And hopefully soon there will be some new drugs, and indeed gene therapy may help too. We've got guidelines on midlife approaches to prevention, which emphasize things like not smoking, taking more exercise, which we all know are good things to do and which will have benefits in terms of dementia prevention as well as general benefits. There are quality standards from NICE, which are concise sets of statements. Do use them if they're relevant to the work that you do, or if you need to encourage others to change. They can be quite helpful if you want to go along and say, look, NICE says this, in terms of encouraging change. And altogether, we've brought all of that into pathways on the NICE website, which I hope will be a useful resource and improve the care for people with dementia. Thank you.